the Secretary of Chhattisgarh Academy of Pediatrics. On behalf of Chhattisgarh Academy of Pediatrics, I welcome all the dignitaries who are present today, our galaxy of speakers and the office bearers of Central IAP and Chhattisgarh Academy of Pediatrics for this today's Tuesday treasures. I welcome our President, Chhattisgarh Academy of Pediatrics, Dr. Kiran Makija sir, who is the brain behind this program, along with Dr. Anup Verma sir, who is the coordinator of this Tuesday treasures. We also have with us our EB member from Chhattisgarh, Dr. Ashok Mehta sir. Welcome you sir to this Tuesday treasures. And today we'll be having a session on allergy diseases. And we have a galaxy of speakers with us. To start with, you have Dr. DIPTI PUJARI ma'am from Pune, Dr. Vikram Patra sir from Mumbai. We have Dr. TUSHAR from AIMS Raipur, Dr. Satyen Gyani from Bhilai, Dr. Prankur Pandey from Raipur. We also have with us many senior members from our state, our respected Padma Shri Dr. A.T. Dapke sir, Gayatri ma'am, Dapke ma'am, Dr. K.P. Saravai sir, Dr. Ashok Tarmaka sir. From the Central IAP, we have with us our treasurer, Dr. Atanu Bhadra sir. We have Dr. Bakul Jain Parekh sir. We have with us Dr. Vineet Saxena sir, immediate past secretary of Central IAP. And I'm missing out the names because of so many have already joined. We have with us Dr. Anand Kesavan sir, Keswan sir, Dr. Ashok Makija sir, and Dr. Gyanesh, who is the president of Durg Villa Academy of Pediatrics, Dr. Rimjim, Dr. Santosh Gemnani, who is the president of Bilaspur Academy of Pediatrics, Dr. Umesh Kurana sir, senior pediatrician from Durg Bhilai, Dr. Sangeeta Joshi ma'am, who is the past AHA office bearer. With this, I welcome you all to our Tuesday treasures. And now I invite our president sir, Dr. Kiran Makija sir, to give his welcome speech. Dr. Kiran Makija sir.
Thank you, Dr. Arun. And today is the very important session on the allergy. So we have the eminent speaker on behalf of Chhattisgarh Academy of Pediatrics. I welcome all the speakers, dignitaries from the national level as well as from the Chhattisgarh also. Senior pediatricians are also and young budding pediatricians as well as the post holders of the different branches from Chhattisgarh also. Dr. Bakul Parekh sir, who is the past president of Central IIP, I welcome him personally as well as I have invited him personally on the WhatsApp also. So after the welcome, I invite him, Dr. Bakul sir and Dr. Atanu sir and Dr. Ashok Mehta sir to say a few words in continuation. So I invite Dr. Bakul Parekh sir to say a few words about the Chhattisgarh as well as today's program and as well as for all of us. Dr.
Thank you. Yeah, thank you, Dr. Kiran Makija. Because of your kind invitation, I thought of joining you for some time. And
thank you.
Thanks to you that I could see many of my friends, Dr. Atanu, Dr. Anup Verma, Dr. Arun Agarwala, Dr. Vikram Patra, and so many others. No, I will not take everybody's name, but I'm really happy to be amongst you. And even the topic today, and of course, before I say about the topic, Chhattisgarh, I have been reading all throughout in WhatsApp and otherwise that since the time you have taken over as a president, many activities are being done in various fields. And I must congratulate you. And I will also request you to keep it up and continue doing your good work all throughout.
Thank you.
And today's topic also was of my interest, to be very frank, because nowadays allergy, pollution, and so much, they are all increasing, no? Means infections are going down and your NCDs are increasing. And one of that is all related to pollution and allergy. And the name which you have given, each sneeze and wheeze, whether there is an atopic march or whether it is related to various other conditions which we see in our day-to-day practice, I think that will be resolved today through the expert talk and discussion. So all the best to you. and keep doing your good work, Kiran. Thank you very much. And my
Thank you very
regards
much.
to Atanu, who is my dear friend and now treasurer of Central IIP, and Dr. Vinit Saxena, again a very dear friend of mine. So both of them, I wish them all the best for their future endeavors. Thank you very much.
Thank you, sir. Thank you very much,
Thank you.
sir. I invite Dr. Tanu, sir, who is the treasurer of Central IIP, to say a few words, sir.
Thank you, Dr. Bukul sir, our 2020 president, and of course our mentor for many of us here. So congratulations to Chhattisgarh Academy of Pediatrics for initiating the academic uh, endeavor. Thanks. I think it needs a lot of effort. So I would like to congratulate both the president and secretary. Kiran, of course, is a very old friend of mine. So congratulations, Kiran, for starting this initiative, and Arun Agarwala, the secretary. And I know all the office bearers and the scientific pillar, Dr. Anup Verma. So whenever Chhattisgarh and point spotters come into mind, it's Dr. Anup sir. So, of course, he has been to Calcutta almost many times, and I think with today's galaxy of speakers, we would definitely have a great learning experience. And I would recognize the presence of our CIPEB member, Dr. Ashok Mehta, and Ashok ji, namaskar.
Namaskar, sir.
Namaskar, sir. And he is also our finance committee member. So it's a great gathering, and I think this is a digital platform. Again, I would remind that it was because of Bokul sir we had got to know what digital platform is, and today we are going ahead even 4 years after the initiation, and even when COVID is not there, we are still addicted to this platform. Back to Kiran sir.
Thank you very much, sir, Dr. Tanu, sir. And now I invite our EB member from Chhattisgarh, Dr. Ashok, sir, so a few words, sir.
Thanks, Kiran. Respected seniors, Anup Verma, sir, Dr. Vinit Saxena, sir. It's a very fortunate moment for me to have DIPTI as a speaker. I remember DIPTI and Jyoti more in the fine arts section when we were students. And it's really proud that our teacher's daughter is going to enlighten us on subjects like allergy. Bakul Parekh, sir, is my neighbor in Ghatkopar where my son is staying. So बकुल पारेख सर इज वेरी क्लोज अतनु बद्रा सर के साथ हम पिछले 3 दिन से साथ में ही थे and due to his Herculean efforts we had a gala time in Darjeeling and without much ado I would congratulate Chhattisgarh Academy of Pediatrics under dynamic guidance of Kiran and Arun to have a blast in this academic parampara which they have started and it should continue in the next regime also. Wish you all the best, Kiran, and all the speakers, Satyen, Tushar sir, DP, and all who are there will have a good, enlightening session. Thanks a lot.
Thank you, Ashok sir. And now much of the time not taking I am, and I invite our academic coordinator, scientific coordinator, Dr. Anup Verma sir, to start the session, who is having all the preparations for today's presentation, sir.
Thank you, Dr. Kiran. And this is another Tuesday treasure, which we are on roll from since last few months. And this is a very successful program which we are conducting across the Chhattisgarh and surrounding state as well. We are fortunate that national leaders are on this platform. Respected past national president Dr. Bakul Parekh sir, thank you for your blessings, sir. Dr. Atanu Badra, the national treasurer of IAP, welcome Dr. Atanu. And Dr. Vinit Saxena is a past national secretary. We have seen working in the last 2 years. Welcome Dr. Vinit. And Dr. Anand Keshwan, past chairperson of neurology chapter. And Dapke sir, very important for us that he has shifted to, physically shifted to Indore, but he is still in our heart. His teaching, his blessings is always there in our OPD, whether we are sleeping, we are seeing our patient, his blessings is always there. He is always used to guide almost all throughout our life. We welcome sir, and as you agree for chairperson to become chairperson in this session, And Dr. Deepti is a national icon in the allergic disorder of, and we have other stalwarts in this allergic disorders like Dr. Vineet is there, Dr. Prankur Pandey, Dr. Tushar, and Dr. Vikram is there. Dr. Gyani, probably he has not joined. So we have a galaxy of speakers, and hope this allergic diseases in childhood will definitely be useful. The panel of the speakers will definitely going to satisfy your all queries in this panel. Dr. Ashok Mehta, we welcome you all. And everybody who has the president, secretary of all the district branches who are gracing the occasion, Dr. Rimjim is here, Dr. Kurana. Hope this session will be very useful for us. May I request Dr. Deepti to start? May I introduce Dr. Deepti? And we all know that she did is MD Pediatrics from Mumbai, DNP, DCH, MRC, PCH. She had an certification of excellence in allergology from European Academy of Allergy, Asthma, and Clinical Immunology. She also to her credited fellowship in allergy and clinical immunology, FACI from Chennai under Dr. Major Nagaraju. And she is at present allergic consultant and pediatrician, affiliation to Dinanath Mangeshkar Medical and Research Center, Pune, visiting faculty at Savita University, Chennai, for fellowship in allergy and clinical immunology. Achievements, she had a lot of achievement to her credit, and the best part is that she is an excellent speaker. We have seen her presentation in various national platforms. The interaction was very fruitful, and she is the first choice in allergic disorder by most of the audience and the pediatricians. Over to Deepti to start your presentation.
Thank you, Dr. Anup Verma, sir. That was too much for me. It's nothing like that. I'll try and do my best. And I'm really honored today to have this wonderful audience. A very big thanks to IAP Chhattisgarh and Raipur for inviting me and having all of us for this session. I'm really blessed to be here. Thank you, Dr. Bakul Parekh, sir, Dr. Vineet Saxena, sir, Dr. Anand Keswan, sir, Dr. Atanu Badra, sir, Ashok Mehta, sir, everyone. All my seniors are there, Anup Verma, sir, and of course, Dr. Kiran, Dr. Rimjim, Dr. Arun Agarwala. All, I'm really blessed, and of course, my father, my mother, Dr. Dapke, and my mother is there. I had told them to keep mute and keep their video off because otherwise they sometimes forget, and that's why they are not daring to open it. So I'm really sorry for this. It's my fault. Okay, so without wasting time, I'll start sharing my screen. The thing is, I've been given 30 minutes to finish off a huge topic, which is itch, sneeze, wheeze. Is it allergy? And spectrum of allergic diseases in pediatric office practice. Why did I choose this topic? Because, see, we keep hearing about allergies all the time. But what really should we do? How do we recognize? Is it allergy or is it infection? And if some allergy comes, some food allergy, some urticaria, what do we do? How do we go ahead in office practice? What about some, wrong investigations that we order, unnecessary investigations, unnecessary avoidance? How to go about simply in our day-to-day office practice? Is that what I'm trying to achieve today? So What is allergy? It is a condition when a person's immune system reacts to substances in the environment that do not bother most people, like simple flowers, trees, pollens, grass, everything, which is somebody's friend is someone's biggest dushman. That is allergy. And depending upon which pathway is taken, when the antigens enter the antigen presenting cell, dendritic cells, they present via the MHC class 2 allergen to naive T cell. And this naive T cell, depending upon which interleukins and cytokines are acting, it takes any of these pathways. And if they are acted by interleukin 4, 5, and 13, we end up into allergic pathway. And TH1 is all infective pathway, TH17, 22 are all inflammatory pathways. So I have presented this slide earlier also, but for those who are joining new, this is my favorite slide made by my own son. Why? Because this is the basis of all the tests that we would be doing ahead. And this is the basis of allergy. What is it? Allergens, they need to enter. Dendritic cells take up. They cross the mucosa. They are presented to the naive T cell. And again, as I said, TH2 pathway is taken when interleukin 4, 5, 13 acts and such a way that the B cells of the body, they start producing allergen-specific IgE antibodies. When we order serum-specific IgE in the blood, this is what we are detecting. Serum-specific IgE that are floating in the blood. This is what we detect when we order our serum-specific IgE. These IgE antibodies then go and attach to the Fc epsilon R1 receptors on the mast cell. This whole phase is called sensitization phase, and we are not allergic till now. We are only sensitized. So a big learning point here in my first slide, when you're ordering your serum-specific IgE and it comes positive, say for peanuts, it doesn't mean you're allergic to peanuts. It only means you're sensitized to peanuts. We call it allergy only if it is correlating clinically. So what does it mean? I'll tell you. When there is re-exposure of the same allergen, say peanuts, there would be cross-linking of the adjacent two antibodies, IgE. Once the IgE are cross-linked, mast cell degranulates. And this mast cell then releases histamines, leukotrienes, cytokines, prostaglandins. That's why we give antihistamines. That's why we give montelukast. That's why we give steroids to counterbalance these mediators. And depending whether these mediators are acting, we get allergic symptoms. Like if they are acting on the eyes, if histamine is acting on the eyes, we get allergic conjunctivitis, allergic rhinitis. On skin, atopic dermatitis, contact dermatitis, urticaria, angioedema, lungs, asthma, and depending on multi-organs, food allergy, drug allergy, anaphylaxis. So in now next 25 minutes, I'm going to quickly go through all these, showing only the main features of each allergy and quickly telling how in office practice we should know what to do next. So coming to allergic rhinitis, why I've kept it first? Because the prevalence is really high. And mainly in our office practice, we get recurrent URTIs. So are they allergy? Are they infections? How do we suspect? Recurrent attacks of cold with or without cough, not associated with fever. It's very, very important. Every time cough, cold, fever, that is your flu, viral infections. Allergy means no fever, mostly, unless it is some very rarely superadded bacterial infection later on. So this is very important differentiating point in office practice. Presence of family history or atopy of self or eczema in the past or food allergy, all these contribute towards allergies. And in such patients of allergic rhinitis, it was seen if we do FeNOs, that is fractional exhaled nitric oxide, the levels were found to be high. I'm not going to go in detail because we are discussing cases in detail in our panel discussion. So these are some of the features which will be shown in panel discussion. So like this patient, this is whatever patients I'm showing, they are all my real office patients. This child comes sneezing, sneezing, sneezing early morning, and look at the eyes, look at the Denny Morgan folds, look at the big eyelashes. They are shouting that I am allergic. Did relevant skin prick tests. Look, this is again a learning slide, because if you see, I have just put one positive control, negative control, 1, 2, 3, 4, 5, 6 allergens I have tested, not 40, 80, 100 and 200. No, 6 allergens I have tested. Why? Because I took detailed history. Only history will guide us what to do. I tried that. I got the history early morning, sneezing, early morning, blocked nose, did house dust mite mainly, and DP and DF both have come positive. Dermatophagoides terinosinus, Dermatophagoides farini. So what I'm trying to say, look at the clinical features, take proper history, and only then go ahead and do relevant test. So how do you differentiate between common cold allergic rhinitis and sinusitis? So we all know allergic rhinitis and sinusitis are for long duration. Onset of symptoms take few days to appear in infection, and immediate in allergic rhinitis. You are exposed to the allergen and you might just start sneezing. And in sinusitis, of course, it may take a few days or even weeks. Treatment is mostly symptomatic in common cold, but in allergic rhinitis, you have to give your antihistamines. Constitutional symptoms are mostly there in common cold, like severe malaise, body ache, headache, and sometimes sinusitis can also cause sinus pains and headaches. Allergic rhinitis is mostly without constitutional symptoms, unless you say eyes. Eyes, they are very itchy and watery, because most of the time allergic rhinitis is present with allergic conjunctivitis. There is very clear watery discharge in allergic rhinitis. Again, very important. Hardly you will see thick yellowish discharge in allergic rhinitis. It's just like patients come, madam, पानी बह रहा है जैसे किसी ने नल खोल दिया है. And fever, as I said, won't be present, and mostly constitutional symptoms are absent. What about ocular allergies? So ocular allergies are a collection of ocular hypersensitivity disorders affecting eyelids, conjunctiva, and cornea, present in 4 to 10% of the children. And by the time they reach adults, it's 25%. And mostly it is associated with rhinitis. So we say rhinoconjunctivitis. Why is it important? Because the allergy season is rising. The greenhouse effect is there. Carbon monoxide, dioxide, pollen. Because of all this, by the time you are adult, the world prevalence is almost 40%. And what are the clinical features? If a child comes in the clinic, what do you see? Ocular itching, watering, redness, foreign body sensation. Very important. Foreign body sensation and continuous itching and scratching of the eyes. When you see, you can see this tarsal conjunctiva. There are so many what I can say in a common layman's person is just granular conjunctiva. And atopic keratoconjunctivitis is one of the very common conjunctivitis. It's like brother of atopic eczema. You'll see dry eye, edematous eyelid, very soreness, itching, tear abnormality, all these are present. And what are the culprits? All your dust mites, pollens, animal tenders, cockroaches, everything. You have to identify it early, otherwise it might even land in vascularization of cornea, which can lead to blindness. And as we know, oral and topical is the mainstay in management. Oral drugs are mostly antihistamines. Topicals are all your antihistamines, mast cells, NSAIDs, steroids, and decongestant. A big word of caution, it's eyes. Steroids shouldn't be used for more than 3 to 5, maximum 7 days. If you are tempted to use steroids for more than 7 days because the conjunctivitis is not coming under control, please refer to an allergist or an ophthalmologist, because again, it might land up into glaucoma. Antihistamines are safe. They can be used for longer duration. What is not allergic conjunctivitis? So your bacterial and viral conjunctivitis, where you get copious yellow thick discharge, you may have constitutional symptoms, fever, symptoms of the bacteria elsewhere in the body. These are not your allergic conjunctivitis. Or your corneal abrasions, Sjogren syndrome, tight lens syndrome, these you have to rule out. And mostly, as I said, allergic conjunctivitis goes hand in hand with rhinitis. Okay. What about asthma? So typically a child of asthma will come, midnight cough, dry cough, cough on running, cough on laughing, cough on crying, or breathlessness on laughing, crying, playing, midnight cough. All these point towards asthma. And of course, we have an asthma predictive index. Which child will end up as an adult into asthma? If a child has more than 4 wheezing episodes in a year and at least one major criteria, that is physician diagnosed atopic dermatitis, parental asthma, all these again showing atopy, and allergic sensitization to at least one aeroallergen. So for predicting asthma, you have to do your allergy tests, or at least 2 minor criteria, that is wheezing unrelated to colds, eosinophil count again more than 4%, allergic sensitization to these foods. Again, allergy comes here. You need to have your allergy test for your major and minor criterias both. But beware, again, I'm not going to go in details. We are covering this in panel discussion. You have to differentiate your asthma triggers, which are all your pollutants, from your asthma allergens. These are all your outdoor allergens, your grass and molds, and these are indoor allergens, dust mites, dog, cat, dander, cockroaches. What about atopic derm? So again, I'm not taking asthma in detail because 30 minutes is just too less. We can have a whole session on asthma. You all must have already had it. I'm just trying to tell how will you think of asthma when a child comes in office practice, and what allergens would you think of? Now, what about atopic dermatitis? Again, we are doing it in panel discussion. This is your childhood atopic dermatitis, needs to be detected early in life because we don't want this chronic atopic dermatitis kids. Just yesterday, I saw one patient from Bahrain that she had come, and for 1 year, 1 hour, that 8-year girl was crying. She was so fed up of her simple atopic dermatitis. So that can be really, really stressful for the person who is dealing with it day in and day out, scratching, not able to sleep. Her friends in the school were avoiding her. They were teasing her. So, you know, looking at it is just dry skin condition, but person who is suffering can be in a lot of trouble. So we need to identify. Now coming to the real clinical practice scare, what I can say is urticaria. Urticaria can be really difficult to diagnose and sometimes even difficult to treat. So let me go through few quick cases of urticaria. Now, all these are real cases. This is during COVID time. We were doing teleconsultation. So this person calls me and saying, I'm having this type of rash since 6 to 7 years. And it subsides on taking Allergy. I have not shown anyone because it subsides on taking Allergy. Now, the point was, he didn't even come to show me this rash. He said, I want to know whether I can take COVID vaccination. And he said he has done all these investigations. He's strictly avoiding all this, but the rash continues to persist. Why? Because look at the test, food intolerance test. What has food intolerance to do with urticaria? Remember one thing, chronic urticaria is rarely ever food allergies. Only acute urticaria is food allergies, infection, and drugs. So all your NSAIDs or your antibiotics, acute urticaria. Infection, acute urticaria. Food allergies, acute urticaria. You eat here and you will get urticaria. Urticaria going on for 8 months, 10 months, 2 years, 6 years is hardly ever your food allergies. And he has on top of it done food intolerance test, which detects IgG and not IgE. So that's why no wonder he's avoiding all agar-agar, amaranth, egg white, and all these fish and cola nuts, and he's still having. I had to call that patient in because his rash, as you see, was very typical. Can you see these scratch lines? When he came to the clinic, I just scratched him with my nails, and there you go, these 2 straight lines. He was nothing else but dermographism. Again, it will be dealt in a panel discussion. You need not do any test here. It's just wherever he'll scratch, he'll get this rash. You have to tell him not to scratch and put him on long-term antihistamines. Let's see one more case. So you saw unnecessary tests done, unnecessary foods avoided, miserable life, not able to eat anything. We have to refrain from doing all this. One more case, 48-year-old, she's saying she has lost 5 to 6 kgs of weight. She's having severe urticaria, unable to stop antihistamines since last 3 to 4 years. And again, she WhatsApped me for everything possible. She has allergic to all possible NSAIDs, multivitamins, all nuts, peanuts, everything, all, even vegetables, dals, you name it, green tea, coconut, vinegar also. I don't know how. And she has done all possible tests, all antibodies, ANA, PNK, CNK, everything, including duodenal biopsy. So, and look at this, her ANA blot. On examination, and she had been sending me these photos. This is her urticarial rash, then sometimes this. So this was the catch point. That's the importance of history and examination. She had been dealing with this condition for the last 7-8 years and done so many tests. But what has so many foods to do with rash only? Now she says she's allergic to green tea. Why green tea will produce rash only here, only here, only here? So definitely this is not a food allergy. We had to call her to the clinic. One of the nurses supervised her, made her eat in front of us. Nothing happened. So she was psychologically disturbed. She was producing this rash on her own. We referred her to a psychiatrist and now she is doing fine. So you see, unnecessary tests, unnecessary avoidance, this has to be stopped. And this will only happen if we take proper history and do proper clinical examination. So this is the classification. Anything less than 6 weeks is acute, more than 6 weeks is chronic. Chronic, as I said, are hardly ever food allergies. Then chronic inducible, like a dermographism, we can induce them physically. And then sometimes chronic spontaneous, without anything they'll come. In this spontaneous, 30 to 40% will be autoimmune, when person's own IgG will fight against person's own IgE antibody. And the remaining 60 to 70, no matter you spend 10 crores also, it would be idiopathic urticaria, cause not known. So we have to be very careful what investigations we are sending. So these are all your inducible urticarias. It will be dealt later. Now this 9-year-old child came with rash for the last 9 weeks. Again, very irritable, scratching all the time. One positive history I got, ITP 6 months back was given IVIG. This was pointing towards autoimmune. For that, we do autologous serum skin test. We take patient's own serum and compare it with normal saline. Anything more than 3 millimeter than the normal saline, we say autologous serum skin test is positive. This child is a case of autoimmune urticaria. Plasmapheresis is the ultimate treatment, but most of the time we deal with second generation antihistamines. So one more case, this 9-year-old urticaria, since once it comes, it doesn't come under control. Extensive workup done, ruled out all food, infection, vasculitis, autoimmune. This though I only did, was just not coming under any conclusion. And she is a pediatrician's daughter. Then with proper history, 7th time she came to my clinic. And the consultant was also very fine. And then I made 2 + 2 4 because she had once severe reaction after eating strawberry ice cream, then once in birthday cake, gems. She was not allergic to milk, maida, eggs, peanuts, nothing. Then what? The only common factor was pink flower, birthday flower, pink strawberry ice cream, pink gems. So this was her rash, and beware of food intolerance, that is pseudo-allergens. So these are not proteins. We cannot detect them. We cannot test them. There is no test for them in the world. These are all your brilliant blue, indigotine, tartrazine, erythrocine, caramine, all your preservatives, gelling agent, thickening agents, you name it, antioxidants, emulsifiers, artificial sweeteners, foaming agents, artificial aromatics, so on and so forth. Only history will guide you, nothing else. And what is the treatment? Pseudo-allergen-free diet, which is extremely difficult. Look at one simple bread. You think you're allergic to bread, so you can test your wheat and yeast. But no, You look at this E282, INS 170, 1100, 1104, 481, 472, 300, 260. One simple bread has 8 pseudoallergens. One chips packet has 10 pseudoallergens. So beware. Again, you might end up doing so many tests and only history will tell what is the cause. Now, finally, coming to food allergies, again, they are a big, huge topic. I cannot cover it. What I want to try here, see, when we do food allergy test, we do only for this one small part, that is IgE mediated, immune mediated, under it IgE. Rest all these non-immune psychological food intolerances, your lactose intolerance, your pseudoallergens, toxins, non-Ig, your food protein-induced enterocolitis, nothing can be tested. Only history will tell. So for every loose motion diarrhea, if you do full 200 food allergens, that's the biggest no. That's the biggest no in office practice. And how do you get IgE history? You eat peanuts and within half an hour to 2 hours, 3 hours maximum, you should get all your histaminic features. What are those? Scratching, itching, urticaria, watering from eyes, nose, wheezing, coughing, and ultimately anaphylaxis, if unfortunate. This is your Ig. This is where you will do your test. Look at this. 16-year-old female, history of rash and itching on the body after eating besan. Present since early life, now wants some definitive answer. What is the next step? What is the next step? She's only allergic to besan. If at all you want to do besan skin prick test, you can do, or you can do for some other dals, just to make sure she is not allergic to some other masoor, tur, you can do. But she went to someone and that person did all these. What all these? She was allergic to corn, aspergillus. What else? She was allergic to everything, even Penicillium notatum, rhizopus. How come? All these she turned out to be positive. More, so many positive. More, so many positive. And she was given 6 injections of omalizumab. This is a real case. 6 injections of omalizumab, given immunotherapy for 6 months. She was fine. After omalizumab, everyone will be fine. She was fine for 7 to 8 months. She casually ate besan thinking nothing would happen, and she landed up almost touching her death, ended up into anaphylaxis. So my next point, please refrain from doing this. If child is saying that I'm allergic to besan, she's allergic to besan. It's very difficult to do immunotherapy. When you are doing food immunotherapy, it has to be sustained. It cannot be sustained intolerance. It has to be maintained. You start with 1 drop and you can continue, end up into 20 grams, 30 grams of besan, provided that person eats that much of besan every day of his or her life. The moment you stop eating besan, you'll again become allergic. So immunotherapy is difficult in food allergies. The only treatment is strict avoidance. And we should strictly avoid these kinds of tests and these treatments because we are doing more harm than good. So ultimately, what is the diagnosis? History, detailed examination, and some in vivo and in vitro test. In vivo test is your skin prick test and intradermal test. Intradermal test we only do for mostly drug allergies and venom allergies, and patch test. I'll have a quick word for patch test. And in vitro test is your serum specific Ig and component resolved diagnosis. Okay, so this is your skin prick test. This is some of the tests that we do, again, only after histering some 15, maximum 20, and they come definitely positive. And this is how we give the report. So advantages, it's quick. Patient satisfaction is there because they can quickly see. We can do as many as we want. Prick to prick can be done. If the allergen is not present, we can take fresh food and do. And it detects bound Ig. So definitely it is more specific and sensitive. Now coming to one. So in office practice, we mostly do our skin prick tests. What about contact dermatitis? Anything that is coming in contact to your skin. It could be allergic or irritant. What is irritant contact? Irritant contacts are otherwise your friends, like your saliva, urine, feces, solvents, soap. But on repeated exposure to concentrated, like you leave feces in a baby's nappies, the whole skin will become irritant and it will have irritant contact dermatitis. Allergic contact dermatitis is T-cell mediated, delayed hypersensitivity, and it can be to anything right from metals, cosmetics, rubbers, plants, and plastics. So this is your allergic contact dermatitis, and one is irritant contact. Allergic is T-cell mediated, so prior sensitization is needed. Even a small dose can give you allergic contact dermatitis, like your cosmetics, medications, rubbers, resins, and metals. Irritant contact, on the other hand, it is not T-cell mediated. Higher doses, repeated doses are required to give irritation. And it's mostly burning rather than itching. And all your repeated hand washings and obsessive compulsive, you get hand dermatitis. That is mostly irritant contact dermatitis. Okay. So this is one child. During exam cases, I get lot. These are two different children. Can you see lip lickers dermatitis? During exam time, kids start licking their lips because of tension. So you get this lip lickers dermatitis. This child, every time in summer holidays, he would get this because he would wear shin guards while playing cricket. Now, I didn't do patch test, so I labeled it as irritant contact dermatitis due to sweat. But if I do patch test, it could be that he's allergic to this plastic, to this color, to all the materials in it. So it can be anything. Now, this is child, can you see severe rash on the ankles after starting wearing these anklets? And this is not atopic dermatitis. The rest of the skin was normal. Did a patch test for nickel, cobalt, and chromium. He came positive for nickel. This another child, can you see typical rash where his foot is coming in contact with the shoes? Again, typical rash where the toes are coming in contact with the shoes. So once this happens, we don't know which material in the shoe is doing this. So we have to do footwear series. We get this series and we have to test all these. This child turned out to be positive for epoxy resins. So what do? We can't say don't wear epoxy resin. We also don't know where is epoxy resin. So we have to tell them, okay, you wear canvas shoes or wear cotton clothes, only then you wear these kinds of shoes. Another female, when she started using this cream, whole face, she got burning and itching and rash. We don't know which ingredient was positive. So again, there is a cosmetic and fragrance series. We have to do patch test for this. And she turned out to be positive for lanolin, that is wool alcohol. And in such cases, we have to tell them that they have to read the ingredients. And if they find lanolin, they shouldn't buy that product. And how do we do? These are all the syringes in which the allergens are present. These are the wells. We have to remove this sticky tape, put these allergens inside the wells and stick the wells on the back, depending upon how many series you want to do. So one set of patch you remove after 48 hours. The second set of patch you remove after 4 days, 96 hours, and then you read. Can you see this patient? Can you see the dots? So this allergen was positive in this patient. This is how you do your patch test. So diagnosis is 1 + 2 + 3+, depending upon how bad the reaction was, whether it was just a mild reaction, erythema, or vesicles or bullous lesions. So now that we have covered even our contact dermatitis, what is the treatment of allergies? Avoidance, avoidance, avoidance is the treatment of allergies. Let it be anything. Aeroallergen, dust mites, avoid. You have to avoid your allergens. Food allergens, avoid. If avoidance is not possible, or in spite of avoidance you are getting, then pharmacotherapy is the next best. If pharmacotherapy is also not helping, then the only thing you can go for is immunotherapy where it is possible. So primary prevention is always the best. That is preventing diseases even before they have appeared. So like vaginal delivery, kangaroo care, exclusive breastfeeding, this will all increase your Th1 cell line and decrease your Th2, because maternal microbiota will increase your infective cell line. So this is the way to prevent allergies. So all this should be done in pregnant mother. She should be, and breastfeeding is one thing that should be continued for 6 months, which will give your IgA and lot of maternal microbiota. Last but not the least, immunotherapy. It's either subcutaneous or sublingual. So like any vaccine, if the child is allergic to house dust mite, we give house dust mite immunotherapy. And the effect of the immunotherapy persists even on stopping it. But again, there is a big exclamation mark here. It has to be given minimum for 3 to 5 years. As I said, subcutaneous, we get a lot of local irritation and side effects. So there are a lot of dropouts. The patient has to come to your clinic to begin with twice a week and then once or twice a month for at least 3 to 5 years. So sublingual immunotherapy is more famous in our country. Sublingual drops can be taken at home, but it's more expensive because the dose of the allergen is very high. Failure, the biggest cause of the failure is when you have given immunotherapy when it was not even needed, like our basin patient. Okay. So my take-home message, allergies are on the rise due to lifestyle changes. Proper history can help us find out which allergen is culprit. Skin prick test and patch test are gold standards. Best treatment is strict avoidance of the offending allergen. Immunotherapy is the best where avoidance is not possible, but if started, has to be given for 3 to 5 years. Only genuine and correct tests should be done and treatment should be tailored according to your test and diagnosis. Only then your allergies will be cured. And this is my patient where I was very impatient. It was beginning of my practice, did positive histamine, gave normal saline, negative control, didn't wait, did skin prick test, everything came positive. But that was a big learning thing for me. My negative control, normal saline should have been negative. But even this is positive. I should have waited. This was a case of dermographism. I shouldn't have done the test here, but it was a big learning point for me. Thank you.
Thank you, Dr. Dipti, for a wonderful presentation. And I have no words to say that the gist of this your lecture, you have covered almost most of the common allergic disorder in OPD practice with how to treat and how to go ahead, how to order allergy test and how to interpret, and so many things you have made it very, very clear. Uh, Hope this your lecture will be worth preserving and it will be helpful for we pediatrician in office practice. Over to Dr. Arun to please continue ahead.
After a wonderful lecture from Dipti ma'am, we have with us Dr. Tushar JAGZAPE from AM Raipur, who will be, as Dr. Dipti madam have said, that the most important management of allergic diseases will be avoidance, avoidance, and avoidance. And to speak on it, while we are managing our allergic diseases, we should not forget our environment. And to speak on this, I invite Dr. Tushar JAGZAPE, who is the additional professor in pediatrics at AIMS Raipur, who is MD, MPhil in HPE from GSMC, IMER, and a diploma in allergy DJs from CMC Vellore. He has more than 25 publications to his name in various journals, and he has been authored many chapters in many pediatric books. He has been an executive member of Environment and Child Health Group of IAP. He is an ex-member secretary of IEC AIMS Raipur. He has also been awarded the Best Poster Award in the respiratory section at Pedicon 2018. And his areas of interest is childhood allergy and asthma, general pediatrics, and medical education. With this, I invite Dr. Tushar JAGZAPE to present his talk. Tushar.
Good evening, everyone. And at the outset, I would like to thank Chhattisgarh Academy of Pediatrics, Dr. Kiran Makija sir, Dr. Anuparma sir, Dr. Arun Agarwal sir, for giving me this opportunity. And after listening to madam's lecture, I feel that I feel that I will have to give a lot of efforts to give justice to my topic. And my topic today is managing allergic diseases. Don't forget the environment. So in next 15 to 20 minutes, we'll be discussing about what is environment, what is an external environment and internal environment, how environment exposures are related to allergies, what are the common outdoor and indoor allergens, and 2 or 3 case studies. So what is environment? So environment is a condition that surrounds someone or something. So this condition also influences the growth, health, progress of someone or something. And the environment includes living as well as non-living elements like air, water, plant, animal. Everything is a part of the environment. The environment can be internal environment, can be external environment. Internal environment is nothing but composition of the human body with respect to various tissues. Every individual's body is different. The composition of the body tissues is different. Their personality is different. So internal milieu is something as internal environment. So like obesity, atopy, and stress. All these are part of internal environment. The external environment it basically includes exposure to various microorganisms, viral infections, molds, dog and cat exposure, traffic-related air pollution, and tobacco smoke. So these are mostly related to development of allergies. So my topic or my talk would be mostly dealing with this, how this environmental exposure associated with allergies, and how we should take care of them when we are managing allergies in the office practice. So let us come to the first external environment, that is microbial environment. So we know that our body has more bacteria than our total body cells. So the exposure to microorganism is very much related to development of allergies or prevention of allergies. So many studies have found that the more diverse microorganisms, the more exposure to diverse microorganisms, it is more protective against development of allergies. So studies have found that when the children are when the children stay in rural areas or in farm area where there is more exposure to endotoxin, there is less allergy. So this study, which was done in a population which has a common origin, when Finnish population and Russian population, the origin is common, but their environment or their socioeconomic status is different. In the Finnish population, the patients were of higher socioeconomic status, whereas the Russian population was were poor and living in rural farms. So they found that the allergies were less in this Russian population, where the population was poor and they were living on the farms. Similar studies were done in China also. They also found that early life exposure to various farm animals are protective from development of allergies. The most important part is not only the amount of microbial exposure, but also the timing of microbial exposure. So early bacterial exposure is protective against development of atopy. Most of us are aware of the hygiene hypothesis and the old friend hypothesis. This is a part of kind of supportive of protection of bacterial exposure against allergies. The next is viral infections. So as a pediatrician, we find that most of our babies less than 5 years of age, they come to us with some respiratory infections and wheezing. Most of these wheezing is associated with viral respiratory infections, influenza virus, influenza virus, human metapneumovirus, then rhinovirus. All these can cause wheezing. There is an evidence that the more severe is the viral infection-induced wheeze, more is the risk of having asthma or exacerbation of asthma in future. The human rhinovirus is a robust marker. So whenever human rhinovirus-induced bronchiolitis, severe bronchiolitis is there, there is a high chance that the child will develop asthma in future. And early life acute respiratory infections because of viruses and associated allergic sensitization to aeroallergens increases the risk of asthma. Then comes the molds. The molds are ubiquitous. They are present everywhere. So how do we know that there is exposure to molds? you can have visible fungal growth on the walls. There could be dampness, or there could be odor. So this should be asked in the history. And the fungal profile, it changes with the season as well as the geographic location and ventilation. One review which was done by the Institute of Medicine regarding indoor environment exposure and exacerbation of asthma concluded that there was a causal association between dampness or dampness related agents and asthma exacerbation in children. Numerous studies have also found association of indoor fungal exposure to asthma, allergic rhinitis, eczema, but some studies also suggest that mold exposure could be protective. This particular study found some evidence that mold exposure could be protective. So as I said with the bacterial exposure here, the timing of exposure probably and the type of the mold exposure probably has a more effect whether it is protective or otherwise. Coming to the next environmental allergen, that is dog and cat exposure. Again here, the evidence is mixed. Some studies suggest that there is a risk because of dog and cat exposure, whereas some studies, they say the dog exposure especially is protective against development of allergies. The most of the studies say that the pet exposure during first year of life is protective. Like this Swedish birth cohort study, they found that if there is a dog exposure during the first year, it reduces the asthma risk by at 6 years of age. But overall cumulative evidence regarding this is inconclusive, and it says that there is no increased risk of allergic diseases from pet exposure. However, it should be noted that somebody who has already developed sensitization to some allergens, and especially dog or cat allergens, then the exposure to cat and dog allergen may increase asthma exacerbation, or control of asthma may not be good in these patients. Now, coming to the next, that is air pollution and trap. All of the world, including Raipur, Chhattisgarh, is suffering from huge air pollution. And this air pollution is present also inside the house as well as outdoor. The outdoor air pollution is because of various gases which are produced because of the combustion of fuels, right, from the automobiles. And the indoor exposure is because of tobacco smoke, some biological materials, volatile organic compounds which are present in our day-to-day things which we use, like furniture, plastics and all. And the most widely studied is the traffic-related air pollution, which actually includes a complex mixture of particulate matter, which consists of black carbon and particulate matter of 10 and 2.5 size micron, and gases emission of nitric oxide, carbon monoxide, ozone, and other gases. The traffic-related air pollution is associated with reduced lung growth, lower lung function, and development and exacerbation of asthma. This meta-analysis found that there is an increased risk of aeroerogen sensitization and food allergy because of exposure to trap. And ultimately this, as we have seen in the previous lecture, the modified asthma index, these aeroallergen sensitization and food allergy ultimately are a risk for development of childhood asthma. And one of the very toxic exposure is a tobacco smoke exposure. Lot of asthma related deaths are actually because of or attributed to the second-hand smoke exposure. The second-hand tobacco smoke exposure is a risk factor for allergic sensitization, allergic rhinitis, atopic dermatitis, and studies have found causal relationship between second-hand tobacco smoke exposure and asthma. Maternal smoking during the antenatal period and the postnatal period has been associated with increased rate of wheezing and incident asthma up to 70%. And even in the absence of maternal smoke, the second-hand tobacco smoke exposure increases the risk of food sensitization and eczema in later age. So these are the common indoor and outdoor allergens. Madam has shown very good pictures of the indoor allergens like pollen, mold, pet denders, dust mite, and outdoor allergens like tree pollen, molds, grass, weeds, and outdoor dust. Now, coming to after we have seen how this environmental exposure is related to the allergies, we'll see two or three cases which we commonly come under our office practice. So, Sumit is a 6-year-old child, was brought with history of chronic cough, which was mostly at the night, running of nose and itching around eyes for 6 months. There was no history of fever or weight loss in this child. There was history of atopic eczema in the childhood. So a diagnosis of asthma with allergic rhinitis was made and the patient was started on inhaled corticosteroids and intranasal steroids. There was significant improvement in the symptoms, but early morning symptoms and cough was still troublesome. So what was the cause? So what we checked the technique and compliance to the treatment. It was normal. So the next step we did was we did an allergic skin prick test, and it was sensitive to house dust mite. So even though the treatment was given well, avoidance of allergen was not done in this patient. So the patient was not doing well. So once this sensitivity to house dust mite was established, and based on the history, we could say that because the symptoms were early morning, the patient is not only sensitized but also having symptoms, so allergic to house dust mite. So house dust mite avoidance measures were advised. And this include use of bed encasing for mattresses and pillows with a pore diameter of less than 10 micrometer. Remove dust mite reservoirs like the toys, stuffed animals, and carpet should be removed from the surrounding. Weekly washing of bedding in hot water, reduce indoor humidity, and use of vacuum cleaner with an HEPA filter bag. Coming to the next case, a 4-year-old child on moderate dose of inhaled corticosteroids. There was no other comorbidities. The compliance was good, but the patient had a partial control. So again here, what was the cause? The first thing which comes to mind is the compliance and the technique of the treatment. The exposure to some allergen was considered, and we took a detailed history. There was no smoker in the family. So what we found that the patient were using mosquito repellent coil for the mosquitoes. Those who are living in Raipur, they know Raipur can be said as the capital of mosquitoes. So what does the mosquito coil contain? It contains insecticide, organic fillers, binders, dyes, and other additives which make it for slow combustion. And the smoke which is produced, it contains lot of allergic or poisonous chemicals like carbon monoxide, particulate matter, polyaromatic hydrocarbons, volatile organic compounds. And you would be surprised to know that one coil can emit the PM 2.5 particle to the tune of which is equivalent to around 100 cigarettes. Similarly, the formaldehyde production because of one mosquito coil is almost equivalent to 51 cigarettes. So if the child is exposed in one night to one coil, so many cigarettes he is getting exposed to, you can say, to so many cigarettes. So once this patient was told to stop using mosquito repellent coil, then the next question which comes to mind of most of the patients would be, if we don't want to use mosquito coils, can we use the liquid mosquito repellent? So this is a study which is a very recent study. In fact, the article is in the press, March 2024. Evaluation of airborne particulate matter and volatile organic compounds released by 3 types of mosquito repellent. Here they studied the liquid mosquito repellent, the mat, and the coil, and they concluded that mosquito repellent emit large amount of particulate matter and VOCs. The emission are largest from oil repellents, followed by liquid and mat repellents. So none of the mosquito repellents are good. They should be avoided so that the patient's complaints or a patient's symptoms, they improve. Sometimes it is kind of easier to take care of the environmental exposure, but in some other cases it may not be so easy to take care of the environment. This is a case of a 12-year-old boy who was on regular treatment of high-dose ICS formoterol, but there was inadequate symptom control and the patient required oral steroids 2 times in last 3 months. Again, here the inhaler technique was good, compliance was good. So we took care of, we tried to identify what are the modifiable risk factors. The child was not obese, there was no GERD, but then we thought of environmental exposure to the pollutants. And when the history was taken, we come to know that the patient's father is a carpenter and he sometimes bring the polished material and other things for polishing the furniture. So these solvents contain lot of volatile organic compounds. The formaldehyde levels are very high in new furnitures. So here, though we could identify what is the exposure, it is difficult to take care of the environment. But we told the father not to try to keep those things in some other rooms and good ventilated areas. But it is easier said than done. So with the help of these three cases, I would like to summarize that allergic diseases have a complex pathogenesis. The genetic, environment, and other factors are responsible. Environment, both living and non-living, should be taken care of while taking care of the allergy histories. Complex interaction of environment is there for the development and exacerbation of allergies. And for optimal management of allergies, do not forget the environment. Thank you very much for the listening.
Thank you, Dr. Tushar, for such an enlightening talk on the environment. As we all know, and Dr. Madam has also highlighted it, that the avoidance of the allergens is one of the most important aspect of managing this allergic disease, and you have already highlighted how to avoid all this and take a good history to identify the allergens that could be causing this allergic disease. Thank you very much. Now I hand over the podium to our President, Dr. Kiran Makija sir, to conduct the further session. Thank you.
Thank you, Arun.
Kiran
And
Makija sir.
after the two wonderful talks from our eminent speakers, we have the wonderful session of the panel discussion. And this is the case based. And I hope everybody loves to hear and as well as gain the knowledge from this panel discussion. And in this panel discussion, we have the galaxy of the speakers. As we have already heard, Dr. Tushar, Dr. Dipti, and one of the eminent faculty is Dr. Vikram Patra. So I will introduce him also. He is from the Mumbai. He is MD DCH fellowship in the allergy and the clinical immunology. He is the consultant pediatric allergist and he is affiliated to the Apollo Hospital and MGM New Bombay Hospital, Navi Mumbai. And he was the ex-associate professor of the MGM Medical Institute of the Health Science, Navi Mumbai. And he is visiting faculty to the Savita University there for the fellowship in the allergy as well as in the clinical immunology. Presently, he is the treasurer of the Maharashtra State chapter of the IIP Allergy chapter. He is very learned speaker as well as having the so much of the textbook. He is the author of chapter of the food allergy, IIP standard treatment guidelines, author of the chapter anaphylaxis, IIP case-based reviews in the pediatric allergies, author of the chapters biologicals and the silk allergy in a comprehensive textbook of the allergy. And he is contributor as well as the national trainer for various IIP allergy modules like the rational evaluation of the allergies in the pediatric practice, childhood allergy disease education, demystifying allergy disorders, and trainer for the IIP United Airways under 5 visas and the cuff module. And along with Dr. Patra, Dr. Satyen Gnani, who is the learned speaker from the Bhilai itself. He is the past president of the Durg Bhilai branch, and he is having special interest in the allergic disorders in the pediatric population. And along with Dr. Satyen, Dr. Prankur Pandey, who is the presently is the president of Raipur Academy of Pediatrics, is there in the Pandit JNM Medical College as the professor. So I will invite all the faculties to start with the panel discussion, and the lead panelist will be the Dr. Tushar.
Thank you, sir. Let me welcome my fellow panelists, Dr. Dipti Madam, Dr. Vikram, Dr. Satyen, and Dr. Prankur. So we know that allergies are very common and allergies are increasing. And though allergies do not cause much of morbidity, much of mortality, but the morbidity associated with allergies is very high. And to take care of this morbidity, we need to have proper management, evaluation and management of the allergic cases. So through this panel discussion, we'll try to take you through the common cases which we see in the office practices. So let us begin with the first case. I think, yeah, okay. So case one is an 11-year-old Ramesh. He has severe itching with raised patchy rash on the back and both shoulders since last 2 to 3 months. He was advised tablet Atrax by a general practitioner, because of which he started having excessive sleepiness and it was affecting his school concentration. So one of the dermatologists started him on levocetirizine, but there was only temporary relief. The rash would come back on stopping the medications. So the patient was referred to an allergist. The case was reviewed. The hives were only limited to back and shoulder, and mostly during the morning hours on reaching the school and in the evening after coming back from the school. So let me put my first question to Dr. Satyen. Dr. Satyen, what do you think is the child suffering from, and how do you classify this condition?
See, this is clearly a case of urticaria, and it is happening at a specific place and at a specific time. So the place where it is happening is because of the school bag which he is wearing. So it's a pressure which school bag is causing, and it's a pressure urticaria. So when we classify urticaria, Dr. Dipti has already mentioned, but I like just a revision sort of thing, that urticaria may be acute and chronic. We call urticaria acute if the duration is less than 6 weeks, and chronic if it is more than 6 weeks. So this child is having chronic urticaria, and chronic urticaria is further classified into chronic spontaneous urticaria, where there is a spontaneous appearance. More than 80% of the cases are spontaneous urticaria, which are idiopathic. And then there are some factors which induce an urticaria, commonly, which is physical urticaria, like dermographism is the most commonest thing. And then cold urticaria, which happens on exposure to cold, delayed pressure urticaria, which happens after some time of a pressure in some area. And solar urticaria is due to heat, sun. Heat is because of heat. Vibratory angioedema happens due to any vibratory movement. Cholinergic happens when there is a lot of cholinergic activity, like anxiety or physical exercises or spicy food you have. And then contact urticaria, which develops after coming in contact with some allergen, and aquagenic is after coming in contact with water.
So thank you, Dr. Satyen. Chronic urticaria is really a difficult case. So let me ask Dr. Prankur, how do we evaluate such cases?
So in case of chronic urticaria, ideally our approach should be first to confirm the lesions, whether they are hives and angioedema, and then we should take a detailed history and do a proper examination to rule out other causes which can present with wheals and angioedema. And once so our history has made a diagnosis of chronic urticaria, and especially if we are moving towards chronic inducible urticaria, then we can do some in-office provocation testing to decide which subtype of chronic inducible urticaria are we dealing with, and also determine the threshold. Like in this case, this child had hives, especially on reaching school and after coming back from school. So that indicated that pressure of that straps of the school bag had led to the manifestation, and especially the timing was also correlating. So in such case, we can do the pressure test. We can use a sandbag or a sling, which can be applied, which can be used to apply perpendicular pressure to the skin surface for at least 20 minutes, and then we can watch for the development of angioedema and urticaria in next 5 or 6 hours. So such kind of in-office testing can help us to find out various inducible causes of urticaria.
Thank you, Dr.
So that
Prankur.
should be our approach when we are inducible urticaria.
Yeah, thank you, Dr. Prankur. You have detailed in detail about the evaluation of chronic inducible urticaria, but more commoner than inducible urticaria are the spontaneous urticaria. So my next question is to Dr. Vikram. Dr. Vikram, can you specify or tell us how to evaluate chronic spontaneous urticarias?
Thank you, Dr. Tushar. And at the outset, let me thank Chhattisgarh IAP for the given opportunity. As already mentioned, the classification, I will not go into the detail again for the classification, but as you can see, and in the previous slide also it was mentioned, the bulk is chronic spontaneous urticaria. Without any trigger, the urticaria can come. Now, 75% of the cases of chronic urticaria, they are because of the chronic. And out of them, only 25 to 30% are autoimmune, and rest, as Dr. Dipti mentioned in her talk, despite of extensive investigation, you are not going to get the cause. So going for the test, investigation, do we need to go for investigations? Yes, our investigations should be history mediated. Now, most of the cases what we get is chronic urticaria. They have undergone various tests, but history has to be elicited. And chronic urticaria unlikely to be due to any food allergy. Okay, so basic test what we need to establish is going for a CBC, CRP, and ESR. And extended diagnostic workup should be on the history to know the underlying cause or eliciting factors, and then ruling out possible differential diagnosis if indicated. Now, there are certain occult infections. Now, from the outside, we may not come to know whether we are dealing with some cause or no. But there are occult infections, like in kids, we can have UTI, we can have dental caries, which can be responsible for chronic urticaria. Helicobacter pylori in adolescents and young adults, they are responsible for chronic urticaria. So we have to rule out. And chronic spontaneous urticaria, as discussed, autoimmune can be the cause. So we can go for autologous skin serum test and the surrogate marker thyroid gland disorders like autoimmune thyroiditis, thyroid hormones, and more than that, autoantibodies. TSH may be normal, T3, T4 may be normal, but autoantibodies, specifically anti-TPO, thyroid peroxidase, and thyroglobulin should be done. And in most of the cases of autoimmune spontaneous urticaria, we get those levels elevated, particularly in adolescent and young adults. Then allergy skin test is rarely required in chronic urticaria. But if from the history we are getting any causal relation, if patient is sure about after eating so and so thing, the child gets urticaria, then we can go for the skin test, and then accordingly avoidance diet can be advised. Then certain systemic diseases are there which can cause recurrent or chronic type of urticaria. So baseline serum tryptase level will help us in coming out with the diagnosis of mastocytosis. And then autoimmune diseases like SLE and other autoimmune conditions. So ANA and lesional skin biopsy will be helpful in such conditions.
Thank you, Dr. Vikram, for elaborating how to evaluate a chronic urticaria. The most important point is the history, and based on the history, we should further progress to further evaluation. So let me ask Dr. Dipti, madam, how do we manage this case of chronic urticaria?
Okay, thank you, Dr. Tushar. So now we know it's delayed pressure urticaria. Why delayed? Because sometimes the pressure may not cause urticaria immediately. It may come even after 6 hours, 8 hours, 12 hours. In this, the child was going to the school having urticaria where the bags were there. So simple, decrease or disperse pressure. How can it be done? We broaden the handles of the bag, widen the straps, the backpack should become lighter. Sometimes we tell to the office goers, avoid sitting in one place for too long so that they can avoid delayed pressure under urticaria beneath the thighs. And one important thing, For all allergic diseases, emotional stress is a big aggravating factor. So emotional stress has to be decreased. These are all non-pharmacological, simple ways which can control delayed pressure urticaria. Now coming to the pharmacological treatment. Next slide, please. So as in all urticarias, we have to treat them till the disease is gone. And sometimes it can be very, very difficult. Patients come to you for disease going on for 7, 8, 10, 15 years. So you have to treat them till they are comfortable, but with as much as needed and as little as possible. So at every step, you can go up or down. I'll tell you in a minute. The first and foremost, first line of treatment is second generation antihistamines. And the most important question I have always been asked is, which one? All are good. So your fexofenadine, cetirizine, levocetirizine, desloratadine, loratadine, ibastine, rupendadine, and now this bilastine. All second generation antihistamines are good. They don't cross blood-brain barrier or hardly cause, and they have least side effects. First generation antihistamines are a big no. EACI, your European Academy and World Allergy Organization, has clearly said they cause delayed in REM sleep, that is your rapid eye movement sleep, and they shorten the REM sleep. So even if we think, okay, first generation antihistamine, we'll give it to small children at night, they'll sleep properly. No, their REM sleep at night is disturbed, so their night sleep is disturbed, and during the day, the next day, they are drowsy the whole day. So no first generation, only second generation. And now for only delayed pressure urticaria, this anti-TNF alpha, etanercept, infliximab, adalimumab, and certolizumab, golimumab, all these are shown to have some good effects, but they are not licensed in children below 12. Next slide, please. So how will you treat your delayed pressure urticaria? We have to follow this table which World Allergy Organization or EACI has given us. It says always start with second generation antihistamine, continue it for 2 to 4 weeks. If the patient is still symptomatic, not getting relief, you can double the dose after 2 to 4 weeks. Still the child or the patient is symptomatic, you can quadruple the dose. So remember, what is the basic mistake we do in our office practice? We keep adding new antihistamines. Fexofenadine se nahi hua, okay, add bilastine, then cetirizine, then Atarax, then no. What we have been told, you have to stick to one antihistamines, double the dose, quadruple the dose. You can do all this after every 2 to 4 weeks. In spite of this, if the urticaria persists, then the add-on therapy is omalizumab. It is anti-IgE monoclonal antibody. The dose is 300 milligram once a month subcutaneously. Okay, it has some side effects, but most of the patients we have seen tolerate it very well. And this can be continued at least for 6 months. Remember, this is an add-on therapy. We have to continue your antihistamines. If the child gets better, you can stop it, but mostly it has been seen once we stop, the disease comes back again. So you have to restart it, and you may continue it for 1 year, 2 years also. The only drawback is it's very expensive. Your 300 milligram will cost somewhere around 15,000. So every month, 13 to 15,000, the patient has to take. If still the child is not coming under control, then the immunosuppressant is the last option, cyclosporin, in the dose of up to 5 milligram per kg per day you can give for 4 to 6 weeks. Then you can slowly taper it to 2.5 milligrams, and then you can continue it for at least 6 months to even 1 year. So this is how you are supposed to follow the protocol for any chronic idiopathic urticaria or even our delayed pressure urticaria. And this is just a guideline, like we have Gina's chakra, we have our allergy chakra also. Every step you have to assess, adjust, and act. You can increase or decrease the dose. It's not that once you start with 120 milligram of fexofenadine, you have to continue. No, you can always increase and decrease. And it all depends on your urticaria control score. If control is good, you decrease. If the control is bad, you increase your medication. Thank you. Steroids is only for rescue medication, not more than 0.3 to 0.5 milligram per kg per day, not more than 7 days. You cannot keep the child for months on steroids. I have seen patients coming, taking steroids for 6 months. No. Antihistamines, that too second generation, are the key. There's no role of topical steroids except for delayed pressure urticaria. You can put local steroid ointments. So prognosis, 50% get better in 6 months, but 10% the disease may persist for more than 10 years. Also, till then, you have to keep treating them till the disease is gone.
So thank you, madam, for elaborating the management. The most important pillar stone is antihistamine, and that too a second generation antihistamine. And you have newer therapies, monoclonal antibodies and immunosuppressions. But I think most of the office practice patients would not need those kind of therapy. So let's move on to the second case. An 8-year-old girl, Shivani, got stung by a bee on her cheek while she was playing in the garden. Because of that, she started having swelling over the face and at the local site. She also became irritable, developed shortness of breath, and became wheezy. Her parents rushed her to the nearby hospital as she became dizzy and weak. So on examination, she was drowsy but arousable, and the temperature was 37 degrees. Heart rate, she had tachycardia, tachypnea, and hypotension. Generalized urticaria was present. Bilateral Wheeze was there on respiratory examination. So probably we all know what this case is, but I would request Dr. Satyan to tell us what are the common etiology of this condition.
So thank you. It is a case of anaphylaxis, and the child is in shock. And the most common etiology is the food. It's food related, and most common food items. Generally, these are 8 items which cause 90% of the food allergy. Then most common is peanuts, tree nuts, shellfish, cow's milk, soya, and eggs and wheat. And it is also caused by insect bites like bee, wasp, and ants. Some medications, some antibiotics, especially penicillin, cephalosporins, can cause anaphylaxis. Ibuprofen, aspirin, and penicillin. Latex, especially the rubber gloves, balloons, condoms, can cause anaphylaxis, and sometimes anaphylaxis is exercise induced. Many of the cases we may not be able to find any cause also.
Thank you, Dr. Satyan. Many times when the patient comes to us with urticarial rash, it is sometimes difficult to know whether it is just a severe urticaria or anaphylactic shock, anaphylactic reaction. So I would request Dr. Pranpur if we can tell what are the diagnostic criteria for anaphylaxis and anaphylactic shock.
Yes, sir. The diagnostic criteria have been formed by National Institute of Allergy and Infectious Disease in 2005 and 6 with a basic thought in mind. Various studies have underscored the importance of picking up milder manifestations of anaphylaxis early so that the patient can be prescribed a self-prescription of epinephrine to prevent anaphylaxis deaths. So this criteria helps us to pick up almost more than 95% cases of anaphylaxis. So that any one of the 3 criteria, if it is getting fulfilled, it is diagnostic of anaphylaxis. So first is any acute onset illness involving skin or mucosal tissue or both, like generalized hives or pruritus or flushing, and at least one of the following: either respiratory compromise manifesting as a wheeze, bronchospasm, dyspnea, or reduced peak expiratory flow, or reduced blood pressure, or end organ perfusion. Second criteria is 2 or more of the following that occur rapidly after exposure to the likely allergen for that patient. So again, out of these 4, if any 2 or more are present, it is diagnostic of anaphylaxis. So involvement of skin or mucosal tissue, respiratory compromise, reduced blood pressure, or persistent gastrointestinal symptoms like crampy abdominal pain and vomiting. And third, if there is a known allergen for a patient, then simple hypotension can be the sign of anaphylaxis, and only one criteria, if it is present, then it can be diagnostic of anaphylaxis.
Thank you, Pranpur. And those skin manifestations are very common and they are present in almost 90% of the cases. It is worth to note that around 10% of the cases may not have skin manifestations at the time of presentation. So are there any supportive lab tests and what is the role of serum tryptase and plasma histamine in diagnosis of anaphylaxis? Dr. Vikram, can you just tell about this?
Yeah. So as discussed, anaphylaxis is a clinical diagnosis. So we must not depend on lab investigation for making a diagnosis, and making diagnosis will be later on to confirm. So we know that all these allergy conditions are mast cell driven. So mast cell, they on degranulation they release various mediators, histamine and other mediators like one tryptase also. Now histamine is also elevated, but histamine peak levels rises by 10 to 15 minutes, and by 30 minutes the half-life is very less. So before we resuscitate the child, histamine level will come down. So we don't do histamine levels. What we do is serum tryptase. Again, if we want to measure tryptase, it has to be done after initial resuscitation only. And the peak of the serum tryptase is around 1 to 2 hours. And by 6 to 7 hours, it comes down, and by 24 hours it comes to the normal level. Then basically, if you want to do the series of in which a series of levels of tryptase are more important, first should be done as soon as resuscitation is done at around say 30 minutes. The second should be done between 1 to 2 hours, and the third one should be done after 24 hours of the anaphylaxis. That level is going to tell us the baseline tryptase level. And anything, the level which was done at around 1 to 2 hours, it should be, if it is more than 1.2 times the baseline level plus 2, then we call it as the diagnosis of anaphylaxis becomes confirmed.
Thank you, Dr. Vikram. So we know that managing anaphylaxis, the role of adrenaline is very, very important. But I would like to request Dr. Dipti Madam to tell us about the various doses and associated symptomatic management in case of anaphylaxis shock.
Sure. Thank you. So as you rightly said, Dr. Tushar, the role of adrenaline cannot be undermined. So it's adrenaline, adrenaline, adrenaline. And remember, it has to be given intramuscular, not subcutaneous, because while you are in shock, your subcutaneous vessels are also vasoconstricted. So intramuscular on lateral aspect of the thigh, 0.01 milligram per kg, undiluted adrenaline 1:1000. Next slide, please. So how will you remember it simply? When you do it undiluted, your dose comes almost for 0.01 ml per kg. So age-wise also you can remember 0.1, 0.3 or 0.5 ml. Or if you want to see weight-wise, up to 10 kgs, 0.1 ml, 20 kgs, 0.2, 30, 0.3, 40, 0.4, 50, and above 0.5. 0.5 ml intramuscular lateral aspect of the thigh is the maximum dose that can be given. You will have to remember this 0.1, 0.2, 0.3. It's very simple to remember undiluted adrenaline intramuscular, because if a patient is in front of you in shock, in anaphylaxis, it becomes very difficult to think rationally and calculate anything. So this simple thing you need to remember. Next, please. So, and if there are any additional features, you have to definitely give high flow oxygen. If there is upper airway obstruction, you'll give nebulized adrenaline. If there is lower airway, Wheeze, you'll give nebulized salbutamol. That we always do. And if there is hypotension, poor perfusion, you'll make the leg end raised. Always remember, tell these patients to lie flat. They shouldn't be sitting during such times, because that can worsen the already present hypotension. Quickly give IV or IO access and normal saline bolus of 20 ml per kg. This all should be done within 5 minutes. And then in next 5 to 10 minutes, you can always repeat second dose of intramuscular adrenaline if no improvement within 5 minutes. And again, you can repeat nebulized adrenaline, nebulized salbutamol, and repeat second bolus of normal saline if the patient's shock is not improving. If the patient still doesn't improve, you have to definitely call for help. In fact, that should be done for the very first time. And you can always give third dose of IM adrenaline. Remember, adrenaline is life-saving. We shouldn't be afraid of giving adrenaline. It will not cause any harm. At the most, it will cause tachycardia and some sweating. But if not given, the patient may die. And you should always have adrenaline in your office. You should have it ready. It's light sensitive, not heat sensitive, need not keep it in the fridge. Keep it ready in a needle and syringe, in a spectacle box or a compass box. And this is a pectoral diagram. You have to lie flat, lateral aspect of thigh, give adrenaline, leg end raised, give oxygen, give normal saline boluses. If need be, you might have to even give your CPR.
So thank you, madam, for elaborating the exact method and doses of adrenaline and the supportive measure in managing anaphylaxis. When anaphylaxis, we know that what we have to give, but when anaphylaxis comes, as you said, in emergency, it is very difficult to rationally think and adjust all these doses and other system also. So let's move on to the third case. It's a case of a 9-year-old male child who presented with a history of rash which was first observed when he was 2 months old, and it started on his face and neck only. Then it slowly progressed to chest and lower limbs. It was very itchy. Every time the rash responded to some cream and lotion, but it comes back again. The mother showed that she was using clobetasol ointment for last 1 year, and the child was mixed feed when he was in early infancy, and now has many restricted food as advised by a general practitioner. His maternal aunt and grandmother have allergic rhinitis asthma. The child and the parents are fed up and want to live a normal life. Dr. Satyan, again, coming back to you for the diagnosis, what this child is suffering from. Can you elaborate on the rash, how it progresses, and what are the diagnostic criteria for this condition?
This is a case of atopic dermatitis, and it's a chronic atopic dermatitis which is going on since years. And when we see the case, what is the prevalence of atopic dermatitis? It's most commonly, it starts at around 1 to 1.5 years of age, and the highest prevalence is in the age of 1 to 4 years, then followed by 5 to 9 years, and the incidence decreases as the age advances. But in old ages, we can see it's a sort of bimodal peak with mild increase in later part of the life. So this is the prevalence of atopic dermatitis. We diagnose atopic dermatitis. It's basically a clinical diagnosis. There are many criteria available, but this is the most frequently used. It has some major criteria and a minor criteria, and 3 major and 3 minor criteria, if they are present, that it confirms the diagnosis of atopic dermatitis. The most common symptom is pruritus. It is universally present, and then there is a typical morphology and distribution. A child under the age of less than 2 years will have predominant rash in over the face, trunk, and it has more of extensor involvement. As the age grows, the face and neck are involved, but the rash is more prevalent on the flexural involvement, like on the elbow and in the knees, behind the knees. Personal or family history, like this child has personal or family history of any atopy like atopic dermatitis, asthma, or allergic rhinitis favors the diagnosis of atopic dermatitis. Minor features may be xerosis, P. alba, some eczema over the periorbital region, periauricular eczema, cheilitis, a tendency towards on a specific hand or foot dermatitis, scalp scale, or there are many other criteria. You can just go on through, and skin in investigation wise, skin prick test reactivity and elevated serum Ig are minor criteria. Remember, the major diagnosis is clinically in this case.
Okay, thank you, Dr. Satyan. Dr. Prankur, quickly, can you tell how to evaluate this case, and what are the lab investigations required, and what are the aggravating factors for this?
Yes, sir. As Dr. Satyan already told, that the diagnosis is mainly clinical. So evaluation depends on history, and we have to see the morphology and distribution of lesions and associated clinical signs. We can ask about genetic history, as in this case, there was a strong family history. Also, we can evaluate the environmental factors like climate, pollution, exposure to irritants, hardness of water. And then we can also see for 3 cardinal features of atopic dermatitis, which are itching, xerosis, and skin lesions. This particular case fits into the childhood type of pattern of atopic dermatitis, where it presents with lichenified plaques and more of a flexural distribution in antecubital fossa or popliteal fossa and volar aspects of wrist, ankle, and neck. And also we can look for atopic stigmata like centrofacial pallor, dermographism, palmar hyperlinearity, pityriasis alba, Denny-Morgan folds, and nipple eczema. So a lot of atopic stigmata can also be associated with this type of presentation of atopic dermatitis. Also, while evaluating atopic dermatitis is known as the gateway of allergy. 75% of cases of atopic dermatitis develop allergic rhinitis. 70% of severe atopic dermatitis later on get asthma. So all sort of allergic disorders can coexist in a case of atopic dermatitis. So they should be assessed for comorbidities also. And also we should assess the severity of the disease. So there we can use CORAD or EASY as an index of severity, which have both objective and subjective measures to assess the severity of symptoms of atopic dermatitis. And next, as far as lab diagnosis is concerned, mostly lab tests are not required for diagnosis because there are no specific biomarkers recommended for diagnosis and or assessment of disease severity. Monitoring of IgE levels is also not recommended. Routine allergy testing is also not recommended. So diagnosis is purely clinical in case of atopic dermatitis. And there can be certain aggravating factors like environmental factors, which include humidity, temperature, irritants like woolen clothes, soaps or detergent or tobacco smoke. Stress can also aggravate the symptoms. Aeroallergens like dust mite, animal dander, and tree pollen, grass pollen can aggravate the symptoms. Food allergens can also aggravate the symptoms. Emotional factors like stress and anxiety may lead to increased scratching, and also increased scratching will further exacerbate the lesions. And also there is more chance of colonization of Staph aureus in case of atopic dermatitis. More than 90% of patients with dermatitis are colonized with the enterotoxin A/B of Staph aureus serves as a super antigen, which further leads to exacerbation of the symptoms in atopic dermatitis.
So thank you, Dr. Pankur. Dr. Vikram, can you quickly tell us about the non-pharmacological management and first-line management of this condition?
Thank you, Dr. Tushar. But you mentioned quickly, but I'll take little time for explaining the non-pharmacological methods, because we all get cases, and I'll ask you all one question. We get atopic eczema in our day-to-day practice. What we get? A child with history of repeated steroid application, right? But hardly these non-pharmacological methods are advised to a patient, and they come to us with repeated steroid application. If we follow non-pharmacological methods, the steroid use will come down. And non-pharmacological methods, believe me, are the mainstay of treatment for most of the mild cases of atopic eczema. And it is these are adjuvant for the pharmacotherapy of moderate to severe atopic eczema. So this plays a crucial role. It is important for having control. We need to explain to the patients that atopic eczema is not going to go within few days or few months. It is going to last. So first thing we should keep in the mind that it is going to persist. Then only they will stick to the non-pharmacological methods to avoid further steroid applications. And the component is patient education. We need to educate them. Modification of atopic skin. We know their skin is sensitized. Their skin is sensitive. So we need to modify the atopic skin. We have to modify the triggers as discussed in the previous question. Then psychological intervention is very important because they come with severe itching and no medication, oral medication helps them in relieving their itch. So first is atopic skin modification. So how to use? The treatment for the modification is moisturizer, moisturizer, and moisturizer. We have to go for emollients, and they are the mainstay in treatment of mild and baseline therapy. Without giving moisturizer, we should not jump to start with corticosteroids. They decrease the severity and the requirement of other anti-inflammatory treatments for disease control. Next slide, please. So now what type of emollient we should use? We should go for patient preference. And we must be seeing many medical representative companies, they come out with very fancy moisturizers. They are very costly. So always look at the patient preference, the affordability, whether they can. If it is not there, a plain simple vegetable oil is also useful. But whatever emollient we are using, it should be used liberally, sufficiently, and frequently. If we prescribe them the costlier one, they will use little bit. they will not use the enough quantity, and that will not helpful in any way. So whenever the child, what we should advise, once or twice? No, we should advise n number of times in a day can be used. Whenever you see your child itching, apply moisturizer. Don't allow the child to itch. Then the technique is soak and smear. So first application should be over the wet skin. When the child comes after bath, a gentle pad with the towel, and then over the moist skin, smear or the gentle application of the moisturizer should be done. And the direction is very important. It should not be like to and fro. It should be along the hair growth in a single direction. Next slide, please. And wet wrap therapy using a double layer of tubular bandages in severe atopic eczema. These are recommended, where we use 2 layers of bandages and after application of the moisturizer. This is the purpose is to occlude to decrease the transepidermal water loss, and it helps in soothing also. Next slide, please. Now bathing, the main question. Now these are all small things we should always direct when we are dealing with a patient of atopic eczema. We have to ensure the child needs to take daily bath. It helps in removing the dirt, scale, crust, irritants. So the atopic eczema is not an isolated entity. They will have repeated fungal infections. They will have repeated bacterial infection also. So in reduction of abnormal bacterial colonization, so bathing and cleansing is very important. Normal soaps, what we use are alkaline. They disturb the skin ecology. So what is recommended? Next slide, please. So the bath should be at least once or twice daily for maximum 5 to 10 minutes duration. So the child should not be allowed to play in the bathroom. Quickly, within 5 minutes, the child should come out. The water should not be too hot or should not be too cold. It should be just neutral to our dorsum of our hand. Then the Syndet bars are useful because they are acidic in nature. The pH is low, which match with the skin pH. So they will not cause irritation and damage. Again, the cost factor is there. Most of the Syndet soap are costlier. And what is important, if they cannot afford, advise, even if they can afford adjuvant therapy of coconut oil application just 10 to 15 minutes before bath, and is very useful to have to decrease the adverse effects of the soap. Bleach bath, again in severe atopic eczema, as I mentioned, coexistence of staphylococcal bacterial infection is there. For them, bleach bath is advisable 1 to 2 times a week for a period of 6 to 8 weeks. Next slide, please. Now, avoidance strategies. After modification of the atopic skin, the avoidance strategies. So identification and avoidance of triggers, control of flares, and prolonged remission is important. Now we know anything which irritates the skin should be avoided. There is no point in treating unless we remove the irritants. So soap, detergent, harsh fabrics. Though double rinsing of clothes when clothes are being washed is advisable, so that the detergent should be removed. Loose fitting cotton or silk fabrics are advisable. Woolen clothes, synthetic clothes, they will irritate the skin further. Then, as mentioned in the slide, that skin prick test has no role. To some extent, it is having role. In case of aeroallergen, there are studies which have been shown atopic eczema sensitized to dust mites. So if it is there, if sensitization is there for dust mites or other aeroallergens, control measures should be taken for them also. Then psychosocial stress. So any allergy, the psychological, Dr. DIPTI mentioned one case of chronic urticaria having some psychological background. So psychological stress should be dealt with, and psychological intervention is very important. Now, as I mentioned, each scratch cycle is there. So in there, that cycle has to be broken. So the cycle we have in atopic are aimed at breaking the each scratch cycle. So you make, if the child, they unknowingly keeps itching, whenever they are doing that, make that unconscious habitual act of scratch conscious. So let them, so when they are aware of that, they stop itching. So we have to make that aware. Then for younger child's hand should be kept busy, and child should be talked in order to distract. We have to distract them from it. Trimming of child's nails is important. And behavioral interventions such as biofeedback and relaxation techniques can also be helpful in controlling scratching.
Thank you, Dr. Vikram. You have elaborated in lot of details and practical hint you have given to our viewers about how to take care of this non-pharmacological management. Now, I would request Dr. Dipti Madam to tell us about pharmacological management of atopic dermatitis.
Sure. So now you must have realized that atopic dermatitis is not just pharmacological management. Lot of non-pharmacological maintaining the skin is very important. But if after doing all this, the child is still having some atopic flare-ups, then you have to use your topical steroids. There are two ways in which you use. For acute flare-ups, there is reactive therapy, twice daily application till active lesions subside, and then you can do only after 2 weeks, step down the strength of steroids. For maintenance, which is also called proactive therapy, twice weekly application to prevent relapses can be used for as long as 16 weeks. So twice weekly can be on Monday, Friday, or during the weekends. And how much? Not liberal use like your moisturizer. Very little, that is 1 fingertip unit method. As you can see from the last crease of your finger to the tip of the finger, that much of cream of steroid should cover 2 palm size area on the child's body which is affected. Next slide, please. And this is the potency table. I have just put few steroids. You should always start with lowest possible potency and go up to higher potencies. Try and avoid high potency steroids in children, especially on face and under the eyelids. And remember, ointments are very potent. Then comes cream, then comes gel, then your lotions, then foams, and then shampoos. What do I mean? Take a simple steroid like, say, Dezonide or your hydrocortisone. So hydrocortisone ointment will be lower to medium potency, and hydrocortisone gel will be your lowest potency. So ointment, then cream, gel, lotion, foam, and shampoos in that decreasing order. Next slide, please. So if you want to maintain or you cannot continue steroids for very long time, then topical calcineurin inhibitors are the game changers. Tacrolimus in children can be used at 0.03%. Again, for acute flare-ups, reactive therapy, twice daily application for 2 to 6 weeks. And for maintenance, which is proactive therapy, twice weekly application. And you can continue up to 1 year also. Remember, never to start with the tacrolimus because it can cause severe stinging and burning sensation. So you maintain the skin first with your steroids, and then there are steroid sparing agents. You can continue with tacrolimus. Next slide, please. Phototherapy, very rarely we don't do it. We always have to refer to skin specialists. UVA and UVB can have some anti-inflammatory and immunomodulatory effects in some conditions. Next, please. Then pharmacological measures which are oral. So antibiotics if there is superadded bacterial infection, or antivirals or antifungals, depending what superadded bacterial infection has occurred. Because remember, there is break in the skin and superadded bacterial infections are very common. Oral steroid, like in urticaria, are for very short duration, not more than 1 week, that too low dose. Okay, only for severe acute flare-ups. Then coming to immunosuppressive drugs, only in refractory cases, you'll use cyclosporin at the dose of 5 milligram per kg, can go up to 1 to 2 years also. And now the game changer is dupilumab. It is till now it was licensed till 6 years. Now we have heard they have licensed to be used in 6 months onwards from the age of 6 months. It's interleukin-4 receptor antagonist, and it also blocks interleukin-13, can be given up to 1 year, almost to 2 years. It's very expensive at the moment, but now Intas is bringing it in India and the cost will go down. And this would be the game changer in atopic dermatitis. Then phosphodiesterase inhibitors, crisaborole and apremilast, they are non-steroidal anti-inflammatory group of drugs. They inhibit interleukin-4, 13, and 31, and they decrease pruritus. So does the Janus kinase inhibitors. They block B cells, T cells, and monocytes. And again, they are very effective in decreasing the itch.
Thank you, madam. You started right from the various potency of the steroids, the form which should be used, and also to the newer molecules. We are running very short of time. I would like to ask the organizers, can we continue with further cases? We have 2 cases, or shall we skip it off? organizer, please.
Yeah, it's almost 2 hours for our session. We have spent so many of the our pediatric colleagues have joined till now, over 70 of them. So they must be having few of the questions also. So we can sum up here and we can take the questions from the audience. So they will be getting benefit by this session.
Okay, thank you, sir. So if there are any questions, the session is open for questions.
Yeah, so one question I read, they said that how long to give second generation antihistamines. So you see, urticaria can be really going on for years and years. So if the patient is well under control with your second generation antihistamines, with your doubling the dose or quadrupling the dose, you can continue it for 2, 3, 4, 5 years also till the patient, and slowly you have to bring the patient for follow-up and decrease the dose slowly till you get ultimately the good control. But even on quadrupling, if the patient is not coming under control, then you switch to omalizumab. Otherwise, you second generation antihistamines, they don't cross blood-brain barrier. They hardly have hepatic effect. You can continue it for really long times. You have to give them. There is no other option. If the urticaria is chronic, you'll have to give them.
There is one question in the chat box. It is related to bleach bath. I think Dr. Vikram would be able to answer this.
Yeah. So bleach bath, as I mentioned, it is recommended to in moderate to severe atopic eczema where we expect co-infection of staphylococcus. So how it is done? It is to be done only once or twice in a week. So how we do the normal household bleach what we have, that is the sodium hypochlorite. You take 5 ml of that, mix in around 15 liters of a bucket. So a bucket which is around 15 liter, mix the solution well, soak a cotton cloth properly, and keep smearing the child, soak the child skin for at least 10 minutes. So that is the better and practical way of having a bleach bath.
Thank you. There is one question from Dr. Rajesh. What about drug-induced urticaria? Can the same drug be reintroduced after a certain time?
No, so, mostly non-steroidal anti-inflammatory group of drugs are notorious to cause urticarias, your PPIs, your carbamazepines. So depending what type of reaction, if you are allergic to non-steroidal, even fixed drug eruptions are very common with your NSAIDs. So once you know you are allergic and you are getting urticaria, you wouldn't be using them again. You'll only use your plain paracetamol. Or then you go for drug allergy testing, your skin prick test followed by your intradermal test, because most of the time it is perceived drug allergies, not true drug allergies, but only perceived true allergies. So you might want to do your intradermal test for delabeling the drug allergies. Once you have delabeled that the child doesn't have drug allergies, your intradermal test is negative, your drug challenge test is negative, only then you will introduce that drug. Otherwise, you will not introduce it again.
Because the second time exposure can lead to even severe reactions like anaphylaxis too.
Yeah, I would like to share one case which we came across a few days back. There was a child who used to get a kind of rash whatever drug antipyretic she used to take, and she was actually told she's allergic to all kind of this drug, but actually that was not a drug rash, or it was actually a physical urticaria which was coming along with the rise in temperature. So this kind of things can happen. I think there are no further questions, so may I sum up
Question is there, Dr. Tushar.
Yeah.
Is there any role of histoglobin?
Yeah,
What
sorry,
is the role?
sorry. There is one question.
Histoglobin they used to use it. They are subcutaneous injections of immunoglobulins. And once upon a time, it was thought that they act very well, but now they are out of fashion. Nobody's using it. They are not licensed, so it's best to avoid. Any allergic panels? Yes, there are some allergic panels when you are absolutely lost. You don't know what is causing sneezing, what is causing asthma. You don't know whether they are indoor or outdoor. You are not getting history, come may what. That time you might want to do aeroallergen panels, or for food allergies, you might want to do veg panel, non-veg panel. So I'm not totally refuting them. Sometimes when you're clueless, you might want to do aeroallergen panels, especially for your allergic rhinitis or asthma.
I can see one question mentioned about the allergen-specific antigen test to be done in chronic urticaria. So as we mentioned, chronic urticaria is hardly IgE mediated. And if we are getting causal relation, then we have to go for allergen specific. And most of the time, urticaria will be related to some food allergen. So in such condition, we can go for allergen specific antigen for that particular. If somebody is having urticaria after eating cashew, let them go for the serum specific Ig against cashew nut only by immunocap method.
Yes, I think so. There will be the many questions from the audience, but due to shortage of time, we have to sum up here only. So I will call upon our academic coordinator, Dr. Anup Verma sir, to say a few words, and at the end, Dr. Arun Agrawala for the vote of thanks.
Sir, before just 1 minute, I would like to thank the sum up this discussion that what most important part in managing allergic diseases is the history. It is the most important diagnostic for any allergic diseases. Investigation should be used and interpreted in the context of the case. The treatment has both pharmacological and non-pharmacological components. Allergic identification and avoidance of wherever feasible is important for better outcome. I would like to take this opportunity to thank Chhattisgarh Academy of Pediatrics, Dr. Kiran Makija sir, President of CGAP, Dr. Arun Agrawala sir, Secretary CGAP, Dr. Ashok Mehta sir, National EBM Executive Board Member, Dr. Anup Verma sir, Scientific Coordinator, and all my esteemed and learned panelists, Dr. DIPTI PUJARI, Dr. Vikram Patra, Dr. Satyen Gyani, and Dr. Kanpur Pandey. Thank you very much.
Thank you, Dr. Tushar. Certainly, this is a best academic move from Chhattisgarh IIP to share the experience of this learned elite panel from different part of our country, especially Dr. Dipti, Dr. Vikram, Dr. Tushar, Dr. Satyen, and Dr. Prankur. Absolutely fantastic lectures and panel discussions, and the common case scenarios which we have discussed, and you have shared your experience, and the way one should go, one should think, is really very, very marvelous. Hats off to you. And I request Dr. Dapke sir, who happens to be chairing this session, may I request you, sir, to kindly address.
Unmute. Unmute, please.
सर आपका माइक बंद है।
जोशी जी प्लीज।
हाँ चलो, yes sir, yes, please sir, please.
I am really thankful to all of you. As a matter of fact, it was a very nice learning session, and I am thankful to Anu because he scared me so much that when he phoned me, उसके बाद मैं पानी भी नहीं पिया डर के। There are few points which I thought, if we have the same lecture 5 years from today, what will be happening? If the symptoms of severe allergic reaction, symptoms of certain skin pattern or infection-like situation not controlling, I think the investigation, apart from what has been taken, the short form is GWAS. What is this? Genome-wide association study means we have to do gene-based testing, and this is very important if the situation is in first 6 months or in first 6 years of life. This means apart from the skin problem or the rhinitis problem or the respiratory problem, there is immunodeficiency because certain genes are not working. We are giving them medicines to suppress or overacting, but this will only be corrected if we identify the particular genome which is abnormal. And maybe in another 2 to 3 years, now this has, remember, become a routine testing if there is a neonate with prolonged sepsis, because some of these factors may be responsible, IgG, IgM, interleukins, all this, and they are not able to decide unless genome sequencing and particular gene is also. And this is true for many more conditions years to come. So we have to prepare ourselves along with this management and investigation. Maybe this gene analysis should become a very important component, because this condition is very common. Our country is one of the most thickly populated, most environmental populated, in a difficult situation. Our villages, our roads, our forest, our water, everything is abnormal. And question is why some are not getting something. If we do a reverse questioning, means what are the differences between the two in the genomic structure? And I think the learned speakers today, I know most of them, they are very learned. They should keep getting insight into these problems also. Once again, thank you all very much. I have enjoyed the whole lecture and whole sessions very nicely. Once again, thank you all. Wish you all good luck, good prosperity, and
Thank you, sir.
Thank you very much.
Thank you, sir. Kiran?
Thank you, sir. Thank you.
Thank you very much, sir. And word of wisdom is there for all of us. And many of the stalwarts from the nationwide we have witnessed here: Dr. Harish, Rekha Harish ma'am, Dr. Niranjan sir, Dr. Suman, Dr. Khushi, Dr. Sanjeev. Many of the post holders from the central IIP also were present. So we thanks all of them. So Dr. Arun, kindly go for the formal vote of thanks for our today's session.
Thank you, sir. Dr. Anubarma sir has already mentioned that today's session was one of the best session we have had on the student treasure, and I definitely hope that our esteemed members are now more learned lot to take care of these allergy diseases with more wisdom and scientifically. And for this, I would like to thank our president, Dr. Kiran Makija sir, and our coordinator, Dr. Anu Verma sir, for contemplating and organizing these Tuesday treasures, taking all the pain and effort to contact all our faculties for the same. I also thank the chairperson for today's Tuesday treasure, our respected Padmashri Dr. A.T. Dapte sir, for showering his blessing and being present here today. We are also thankful to our executive member, Dr. Ashok Mehta sir, for his kind presence. And this session could not have been possible with the kind presence of our esteemed galaxy of speakers, Dr. DIPTI PUJARI ma'am, Dr. Vikram Patra sir, Dr. TUSHAR JAGZAPE, Dr. Satyan, and Dr. Valuable time for this excellent session. Many of our central IAP senior members who have joined today with us. We are also thankful to all our senior members and all the active participants of CHHATTISGARH Academy of Pediatrics members who have joined today. And as already Kiran Makija sir have already mentioned it, that nearly 110 members have joined today, which is one of the highest till now in the Tuesday treasures. I would also like to thank our digital partners, Juventus, for providing this platform for this sessions. With this, if any of our members would have any comments, we'd like to invite, otherwise we'll close this session. Thank you very much. Good night.
Thank you for having us. Thank you.
Thank you. Thank you.
Thank you.
Thank
It
you.
was a pleasure,
And
ma'am.
happy
Thank you all
New
of you
Year
very much.
to all of you.
Thank you.
Gudi
Thank
Padwa
you.
and
Bye.
Ugadi.